So the title of the talk today is Cancer Care in the U.S., Challenges of Access and Cost. As I had mentioned, we're going to talk a little bit about how the U.S. pays for healthcare and how it's delivered in oncology, the cost problem, and the type of things people are trying to do. Now, you guys have seen this slide. Everybody around the world, this is what they think of U.S. healthcare. This is it. Look how dumb those Americans are. They're paying so much money for an inferior life expectancy outcome. This is a complicated slide. It's really complicated. And I think one could argue that this more accurately reflects U.S. problems with education, poverty, and probably lifestyle than it does anything else. But the truth of the matter is the U.S. does pay for a lot of healthcare. But you know, if you're an American, this is the way you look at the world. So this data has been presented a million times in multiple different formats. This looks at the 5-year cancer survival rate for common malignancies in U.S. People who live in the U.S. and then people who live in England. And as I think many of you know, for a long time, the U.S. has had superior cancer outcomes compared to much of the world. Now, I don't know why that is. It just is. But this slide, I think, falls strictly under the category of if you have an opinion, you can find data or a slide to support it. And that is why we are in the circumstance we are around the world with COVID, if you ask me, because people have politicized it beyond belief. So do I think U.S. has superior outcomes in cancer? Maybe, maybe. So let's talk about access to healthcare in the U.S. Again, a topic that frequently leads to very spirited discussions. The ACA, the Affordable Care Act, is known colloquially as Obamacare, of course. And so if we look at how healthcare is paid for in the U.S. prior to Obamacare, almost 60% of all healthcare was paid for by employers. We'll come back to that in a second. About 15% was paid for by Medicare. Medicare is national health insurance for the elderly and disabled. And Medicaid being historically health insurance for people who are poor, indigent, typically children and women, pregnant women. And then prior to the ACA, about 15% of the US was uninsured. Now, the ACA did a lot of things. I'm not going to get into that. But what it did do, importantly, were, number one, it expanded Medicaid. It allowed a much more liberal interpretation of what indigent was to allow more people to get Medicaid. And the second thing was it established a marketplace where people could buy health insurance themselves at theoretically a more affordable price. And so the number of uninsured, and this slide is actually several years old, fell to 8%. Now you might say, well, gosh, that's terrible. 8% of your population is uninsured. But I think you should remember that, first of all, there's a lot of people there that are never going to get insured. They're just not. I mean, the U.S. is not going to pay for healthcare for people who are not in the country legally. We'll start with that. That's a political statement. It's not a judgment. Second thing is, Medicaid expansion was actually left to the discretion of states. So there were 50 decisions that needed to be made. And 13 or so states decided not to do it, including the big states of Texas and Florida. So if we could get them to expand Medicaid, the number of uninsured in this country would actually fall substantially, substantially. So let's talk about the difference between Medicare, Medicaid, and commercial health insurance. So Medicare is, as I said, health insurance for the elderly and for people who are disabled. And you know, Medicare came into existence in the 1960s. Contrary to what I think a lot of people think, Medicare is not free. Medicare is not free. Medicare has 4 components, right? Part A, which pays for hospitals. Medicare Part A is paid for by deductions from your salary when you're working. so that you pay now while you're working for Part A coverage when you're an elder American. In addition, Part A has a deductible, meaning you have to pay a certain amount out of pocket before you're able to get the government insurance to kick in. So Part A. Part B is outpatient insurance. It's for regular doctor visits. Part B is a means-tested insurance. As an American, if you have Part B, that means you are paying the government a premium. You're paying them a certain amount of money every month based on how much income you have for health insurance. Now, Medicare itself, Part B, is not free to anybody. In addition to the fact that you have a premium, means tested, you also have a co-insurance. So every service you use costs you 20% out of pocket, okay? Part C is called Medicare Advantage, and Medicare Part C is sort of Medicare in which the government subsidy of the health insurance is actually paid to a private insurance company. And the private insurance company that administers the benefit. So think of Medicare Part C as private insurance not paid for by the employer, but paid for by the government. Medicare Part C has become very popular in this country because it doesn't have the co-insurance and co-payments that Medicare Part A and Part B have. And as a consequence, you get more without paying anything out of pocket. There is, of course, a trade-off because Part C regulates healthcare a lot more than Part A and Part B. And Part D is the newest part of Medicare. That's the prescription drug coverage. That's completely voluntary. In order to get Part D, you actually have to pay for it. It's a premium that you pay a private health insurance company in order to get prescription coverage. So there's a lot of Americans walking around that have hospital coverage and have outpatient medical coverage, but who do not have prescription coverage. So this is Medicare. So when you hear about Medicare for all in the United States, you need to remember Medicare has its warts. Medicaid is totally different. Medicaid is for the indigent, and it pays for everything. For the most part, it pays for everything without any financial contribution from the patient or the beneficiary. And Medicaid, when Medicaid expanded with the ACA, it was probably the single best thing that happened in the healthcare in the United States in a very, very, very long time. And everybody was pretty much behind it, except the states that chose not to do it. And the reason the states chose not to do it is because they were frightened about the fact that they were going to have to pay more and more for healthcare out of the state budget every year. And then, of course, there's commercial health insurance. So as it stands now, about 50% of America gets covered by Medicare or Medicaid, and about 50% of people with insurance get commercial health insurance. Now, on this slide, I've shown you the 5 largest health insurance companies in the US. There are over 900 health insurance companies in the US. Each of them does their own thing, hence part of our problem. Now, commercial health insurance is very important for a couple of reasons. The first is that's how most working Americans get their health insurance. This slide shows over time the percent of Americans that have gotten their health insurance from their employer. It's high. It started happening after World War II, and we won't get into the history of why that happened. But commercial health insurance, which is subsidized by your employer, is for most Americans, let's just say, they think it's their right. It's one of the benefits that they do not want to give up. But employers are facing a huge challenge because of the increasing cost of healthcare. And a lot of people feel very, very strongly that this increasing contribution by employers to pay for healthcare, which is a direct reflection of increased healthcare costs, is why there's wage stagnation in the United States. So this is felt to be bad for the economy. So let's turn to oncology. Oncology is a special case because, as all of you know, cancer is by and large a disease of aging. And so if you look at the commercial health insurance companies, fewer than 1% of their members actually have cancer. But each of those individual cases is very expensive. And so probably somewhere between 10 and 15% of their total spend is on cancer care. For Medicare, for the government, cancer is a huge challenge because cancer is 5 times more common in the Medicare population. And although Medicare pays more for heart disease than it does any other illness, on a per case basis, cancer is the most expensive medical condition. And in the US, the population's aging. So the number of Medicare beneficiaries goes up, which means the amount of money the government's gonna have to pay for cancer care will go up as well. That's why this is a problem. Health expenditures are going up rapidly as a percent of GDP in the US, and everybody, pretty much everybody, feels that something has to be done about the cost of cancer care, cost of medical care. And of course, cancer is often held up as the single use case for doing something about the cost of care. Because if we look at cancer expenditures, they've gone up faster than any other segment of the healthcare spend. So cancer is always in the crosshairs in terms of a medical condition that requires some sort of management. Now, if you ask a payer about why cancer care goes up so fast, they'll tell you there's 3 things. 3 things. The first is the cost of chemotherapy. We're going to come to that initially here. The second is that the US doesn't do a very good job of end-of-life care. And the third is hospitals are expensive and there are avoidable hospitalizations. Drugs are expensive in the US, really expensive. We really didn't understand how expensive until we got access to some Medicare data about how the cancer dollar is spent. And for patients who are undergoing therapy, between 50 and 60% of their total cost of care is the cost of cancer drugs. 50 to 60%. Now, you guys will say to me, well, gosh, you know, when people from the US talk about the cost of drugs, they say, you know, drugs are only responsible for 10% of all medical costs in the US. And that's true, but that's not the question, right? The question is for patients who need to receive cancer drugs, what's the percent of the cost of care that is drugs? It's only 10% in most Americans because most Americans either using generic drugs, which are very inexpensive, or no drugs whatsoever. Even within cancer, if you have cancer and you just have surgery or just have radiation and don't get the drugs, your drug cost is 0. And therefore, obviously, the average cost goes down. But if you get chemotherapy, 50 to 60% of your total cost of care is the cost of drugs. And of course, this is a challenge. Now, I'm pretty sure all of you have seen variations on this slide in the past. On the left of this slide is Peter Bach's data, which was published now several years ago, that look at the increasing cost of cancer drugs over the last 4 decades. And I always like to point out to people when they look at this slide is that that's a logarithmic scale. That it's linear on this slide, but that's a logarithmic scale. So the cost of drugs has gone up just tremendously, massively. On the right-hand side of this slide is an interesting study that was done by Dr. Prasad a long, long time ago, where he actually looked at the cost of drugs at the time of market entry indexed to the magnitude of benefit on the clinical endpoint that led to FDA approval. So if it was survival, it was indexed to the survival advantage, progression-free survival, et cetera. And he found that the correlation between price at market entry and magnitude of improved benefit, the correlation was extremely poor. Or put another way, drugs enter the market at a certain price because that's what the market will bear. And I think everybody in the phone call really believes that that's the case in the US, and it is the case in the US. But here's the problem. We have a law for all Medicare and Medicaid beneficiaries that if the FDA has approved the drug, Medicare has to pay for it, period. Whatever the price is, they can't negotiate the price. That's the law. And not only does Medicare have to pay for it, the individual states have all enacted policies that require the commercial health plans to pay for it, irrespective of the added value and irrespective of the cost. And a lot of people have argued that this specific issue is why there's such a problem in the US, because this specific issue precludes US payers from saying no. Now, it's interesting that this law actually passed in the 1990s. And for those of you who are old enough on this call, you'll remember in the 1990s, there was a big deal about using bone marrow transplant in breast cancer, subsequently proven to be an absolute waste of time and actually harmful to patients. But it became a real political hot potato because insurance companies were refusing to pay for it, saying it was experimental. And patients basically got their representatives in Congress to pay this law, to pass this law so that they could have access to that therapy. Ironically, that therapy has now been completely debunked. But this law exists, and it's hard for me to imagine that this law is going to go away. So US, by law, cannot say no. And of course, that's compounded because right now the FDA, which is the US regulatory agency that determines market access for drugs, has fallen in love with accelerated approval. As you may or may not know, there's sort of been a traditional kind of a pathway by which evidence is presented, trials are done, approval is granted. Historically, that's taken several years. In the last 10 years, especially the last 5, the FDA has decided that that's too slow. We need to get drugs to market faster. They've developed some accelerated pathways. I won't bore you with the details about what constitutes a drug's qualifications for an accelerated pathway, but it should come as no surprise to you that oncology drugs make up probably about 3/4 of all drugs that go through the accelerated pathway. And remember what I said, FDA approves it, it's paid for. And these new drugs do not come to market cheap. They're all expensive. So the drugs are expensive. And this, which we started to talk about in this last call that we had, adds insult to injury. And that is the fact that as it stands right now, the drugs which are produced by the manufacturer are sold to the providers who administer them, and the providers then charge the insurance company a markup, a cost plus. Now, there's a long story about how that happened, and if you like, I'll just send you a reprint of how that happened. But the long and short of it is this. The markup was initially designed to pay for all of the overhead associated with storage, waste, administration, et cetera, because there were no billing codes for that in the US. Unfortunately, it's gotten a little bit out of control. And in fact, at the present time, as you can see on this slide, for most community oncologists, profit related to the administration of chemotherapy is responsible for greater than half of the profitability of their practices. No doubt about it. Drug margin is an important source of income. And this is the system that I just described to you. It's called buy and bill. Buy and bill. Buy the drug from the manufacturer, administer to the patient, bill the health plan. Now, how much do they mark it up? Well, Medicare has a standard drug fee schedule across the country. They pay everybody the same. If you're in a office, in a hospital, whatever, all the same. And the markup is 6% of the published sales price. And there's a national registry that publishes the sales price. However, commercial health plans pay a lot more than that. They pay on average 20%, give or take. So it's been said that at the 6% margin for Medicare, most oncology practices actually can't survive. But that 20% is lucrative. Now, I know, it's crazy, right? Well, if you work for a hospital, it's even crazier. And the reason for that is this. Medicare still pays the hospitals the same way, but commercial health insurance companies pay the hospital based on a percent of the bill that is submitted. Just hospitals have this imaginary number for every service. They have contracted a percent of that charge through the health insurance. So in fact, hospitals get paid a tremendous amount more than community oncologists do, and they mark up the drug an insane amount. So oncologists, I told you, get 20%, hospitals get 400%. 400%. So as we think about fixing this system, commercial health insurance and Medicare, they have different stakes in this game, right? They have different exposure and they have different pain. And so as we think about solving the system, and as I described to you, the two things that people have tried recently, the goal is to try to find a system that works for everybody, right? In Medicare, there's a part of Medicare called CMMI, the Center for Medicaid and Medicare Innovation, that allows the government to do a kind of experimental things in payment. And about 5 years ago, they decided they were going to do a pilot, an alternative payment model pilot in oncology. And it was called the Oncology Care Model, OCM. And what they did was this. The practices had to volunteer. And if you volunteered, they said, okay, listen, we're going to continue to pay you fee for service, but we want you to expand the services you give the patients. And in order for you to do that, we're going to give you a little extra fee, and then we're going to do a truing up. We're going to find out how you did compared to a prorated modeled price tag and compared to your colleagues. So there's this thing called a performance-based payment. So they said, look, we're going to hold you accountable. We're going to pay you a regular fee for service, do whatever you can to get good care, take care of patients, keep them out of the hospital, etc. We're going to give you this management fee, and then we're going to compare your cost to what we predict your cost ought to be. And if you save money, you get some of it back. But if you don't, you got to pay some back to us. It hasn't worked. It hasn't worked. And it hasn't worked, I think, because over the 5 years, what we've learned is that people don't get admitted to the hospital all that much when they're getting chemotherapy. And I'll just tell you that both from my own personal experience, but also that's what the studies show. But in addition, the medical cost inflation that is related to drugs has just swamped everything. It's just completely eclipsed everything. So after 3 years, these are the results after 3 years, the program has actually cost the government many millions of dollars, which is unfortunate. So why don't we go after the drugs? So there has been an effort to go after the drugs, sorta. This is work that I have been involved in for a long, long time. The idea is that there are value-driven choices that oncologists can make that would save the system money, right? There's a lot of therapies that either don't work or don't work any better, but cost more money. So if you could take all the appropriate treatments and then filter them for toxicity and cost, you could come up with preferred treatments, and you could reward practices, physicians, for the preferred treatments. These are called evidence-based clinical pathways, treatment pathways. And it was based on this observation, and again, this is work I did, 15, 18 years ago. There was a lot of debate in that time in lung cancer. There were lots of different treatment programs. On the left is a very famous article that basically showed the outcomes were the same for all of those treatments. And on the right, you can see the differential in cost sevenfold from the least expensive to the most expensive. So we said, what the heck? Why don't we find one or two of the least expensive and promote those? And the way we did it was we actually embedded it into the electronic medical record. So when a physician entered a certain clinical profile, they were presented with choices, and then we were able to keep track of how they did. And the initial work here showed, and this was published 2008, I think, no, 2010, was that the clinical outcomes were the same and the cost was less by a third. So we got excited about this, and for a while, insurance companies got excited about it, and we tried to roll this out across the country. But the problem is this. We've actually gotten better at treating cancer. We have. The survival rate for patients with lung cancer has improved quite dramatically, at least partially because of the introduction of effective therapeutic measures. And those therapeutic measures, they're really expensive, so you can't leave them out. So pathways are an approach. They don't get at the root problem of unit cost, but they do look for therapeutic equivalence. We actually have seen a little bit of this in this country with biosimilars. Now, you guys in Europe, you know all about biosimilars. We're relatively late to the game. But now, increasingly, biosimilars are being prescribed, promoted in the U.S. cancer space, and they've actually generated some savings. We won't know for sure exactly how much for a little while. The market's not mature, but biosimilars are a variant on this discussion. So what if you put the two together? What if you take that care delivery model, that was the oncology care model, and add in pathways? And this is work I did when I was at Aetna with a very large physician group in Texas, and we showed that if you put them together, you actually get contributions from all of the approaches, 20% savings. But I'd suggest to you that this is a little bit, this is, I think, a little bit dated. It's a little bit dated. So I've told you that what's been tried by the government, this care model, oncology care model, and what's been tried around drugs, pathways, they haven't worked very well. And I would tell you that I think it's highly unlikely that either one of them will substantially lead to savings in oncology in the US. So it's my opinion that we need to do something a little bit more drastic. Now, right now, not many people in America like our last president very much. There's pretty good reason for that. But he did do some interesting things. And right before he left office, he proposed something which he called most favored nation pricing. Forget about that populist term. What it was reference pricing to the best available price in developed nations, all of whom use health technology assessment. Now, you might say to yourself, well, goodness gracious, why doesn't the US use health technology assessment? It's political. Politics and healthcare don't belong together, but it's political. And I don't think we're ever going to have HTA uniformly agreed upon in this country. However, the idea of indexing price, using some sort of reference pricing to the prices that are paid in countries that use HTA, I think it's gaining some traction in this country. And I would not be surprised if the current administration chooses to pursue this path. Now, this, of course, will have substantial impact on the cost of cancer drugs. Several of the models that looked at this proposal suggested that the cost of cancer drugs might drop by as much as 2/3 over 5 years. So that's a heck of a lot more than the nibbling around the edges that I've shown you with the programs that have been done to this point. The second thing is, and we got into this a little bit on our last call, is that I think it's very, very likely that the government is going to eliminate the buy and bill system, this idea that physicians or hospitals get a markup on the drugs. If nothing other than the fact that there's the appearance of impropriety, which is absolutely true, it's going to go away. And I think that's fine. Here's the problem. There's two, in fact. One is that the current system is incredibly efficient. It really is really an efficient delivery model. The second problem is, well, let me just refer you to the success that we've had with rolling out the COVID vaccine around the world. I'm going to leave Israel out of this discussion. We ain't done so good in the US. You guys probably know that. We've done lousy. If we put the distribution of chemotherapy in the hands of the government, in my opinion, it's a recipe for disaster. So we have to find a solution that eliminates buy and bill without letting the government get too involved. That's my opinion. And incidentally, I'm a Democrat. But the government is going to move forward with that nibbling around the edges model. They're going to continue with the same kind of care model. I think that this leads to maybe an enhanced care delivery. It certainly adds to the services that a patient receives, but I don't think it's going to generate significant savings. So this is what the government's going to plan to do. This is what they proposed. The current administration really is behind this kind of thing. It really started in the Obama administration. Survived Trump. He left alone. I think it's going to continue. So I don't expect a lot right now of what the government has proposed, but that's what we're going to do. And with that, I'm going to say that we need smart people like everybody on this call start thinking about how do we solve these problems. I think the challenge in the U.S. is the system is so incredibly complex that the changes are going to be difficult, but not impossible. And I think in the U.S. we have to get comfortable with the idea that our problem is unit cost. Our problem in the U.S. is unit cost. Uwe Reinhardt said that a long time ago, and it continues to be the case. So with that, I'm going to stop. I'm going to stop my sharing so we can see each other and invite people to talk to me.
Thank you very much, Michael. If I could ask you, turn your cameras on if you can. Excellent talk. Real right through the American healthcare system in academic detail. So who wants to go first with questions and comments?
Can I ask a question? Just for my information, you explained the different systems for getting reimbursements, the Medicare, the Medicaid, the commercial insurances. What about the managed care, like the Kaisers, and how do they play? Because they that's a can you just, because I missed that in your.
Right. Yes. So I would say that those systems like Kaiser and Geisinger,
yes,
they represent such a tiny, tiny, tiny fraction of the US healthcare system that they probably aren't worthy of much discussion.
Okay.
They really, they are geographically confined. That Kaiser is largely in California, although they are in a few other markets in the US. Geisinger, same thing, small market. Now, the fundamental principle of those, we call them integrated delivery systems, is that the payer and the provider are part of the same organization. And so theoretically they can cooperate and you could control costs because everybody works for the same company. The challenge is that Americans, they don't like to be told where to go for their health care. And in fact, the success of that system depends entirely on the ability of a patient to be, well, I hate to say it this way, but held captive by the system. In other words, if you have a patient that's part of Kaiser, and let's say they develop some complex medical illness and they decide to go to UCSF, Kaiser, the insurance company, has to pay for that patient's care. And it's expensive. And it blows up the entire system. So unless you can keep everything in-house, that kind of system is very, very problematic. The other thing about that kind of system is the doctors have to behave. They really have to listen to what you tell them to do. And for complex illnesses like cancer, those systems have not done that great. They've done it better in the primary care universe, but in complex illnesses like cancer, they haven't done as well because it's really, really hard, unless you have a certain size, scale, and complexity, to be able to deliver all the services that your patient population is likely to need. So, as part of the ACA, as a matter of fact, as part of Obamacare, there was a great deal of interest in developing these kind of integrated delivery networks. And it hadn't gone very far. And part of the reason it hasn't gone very far is because the integrated delivery systems are all based around hospitals as opposed to physician networks. And for all the reasons that I've explained to you, hospitals in the United States, and I'll admit I'm biased, they have absolutely no reason to want to control costs. It just doesn't make a lot of sense for them. So the success of hospitals as integrated delivery systems in the US healthcare system has been modest at best. Patients don't like it and doctors don't like it. Okay.
Can I ask a question?
Sure.
So, Michael, I really enjoyed your talk. Thank you, and I learned from it. Talking about the cost of drugs, clearly, first of all, I'd like to ask you a question about the FDA and whether that could be any prospect of the FDA being reformed. As you know, the FDA has lowered the bar for getting things. You've got, as you showed, the accelerated approval. And the FDA, as I believe, is forbidden to make any decision related to cost.
Correct.
And, research by various people, including Vinay Prasad and people in the UK, AJ Agarwal's group, have shown that of the drugs that have been improved for cancer over the last many years, less than half of them actually improve survival, and only about 10% improve quality of life. And so we have a lot of these approvals based on surrogate endpoints that don't mean anything. So one of the questions, is there any way that oncologists, others can put pressure to get the FDA and the EMA for that matter to approve drugs based more on value than on simply some surrogate endpoint? That seems one root of the problem. And I guess the other question is the problem of lobbying by pharma of Congress, which we know is huge, on both sides of the political spectrum. And clearly their goal is to prevent any type of price regulation. So I wonder if you could just talk about those. Here's a sort of Canadian idealist talking, but it seems sensible that that should change, but is there any hope it could happen?
Yeah, and again, this is my personal opinion, both based on my experience as well as sort of the kind of thing that I do in my day job. No, I think the access boat has left this. The access train has left the station. There's a strong feeling in the U.S. that part of the reasons that we're willing to put up with the high price of medical care is because we get access quickly. The fact that we get access to stuff that don't work doesn't seem to matter very much. But I do believe actually there's a couple of possibilities. I've recently been involved in a number of discussions regarding the FDA's responsibility post-marketing. So, you know, part of the societal compact, if you will, with accelerated approval is that you close the loop on the back end and prove that the stuff works. And if it doesn't work, then you don't get access no more. In fact, there's been studies done and published. Aaron Kesselheim at Harvard has published some on this subject with about the issue that technically required post-marketing studies are often not done. And not only are they not done, they rarely replicate the results in the regulatory trials, the registration trials. And so one way we could get at this is if it doesn't work, it needs to go. Now, we have seen one example of that in the last year. There was a sarcoma drug that was approved by the accelerated pathway that has subsequently been removed from the market. But there's a million other examples. Honestly, if we could do that, I think that would help. Second thing is this. I think you can manage a lot of the cost through pricing, or more exactly reimbursement. The FDA won't do it, but I think the idea that that a market entry price is something akin to, let's say, what's done in Germany, for example, might be a solution that U.S. could get their hands around. We'll see. The current president, as well as the Democratic House of Representatives, have both expressed strong feelings that they want Medicare to negotiate prices, and I think that's going to happen. The third thing is that I think lobbying is also problematic. It's problematic because there's literally 50 years history of an attempt to reform campaign financing in the United States. It's failed miserably because, frankly, we're talking about taking away legislators' money. They don't want us to take away their money. So no, I don't think that's going to happen. And the fourth thing is that the other thing I've been involved in some lately, and I think it's an interesting idea, is the use of outcomes-based contracting or outcomes-based pricing. That is an unrealistic strategy for the vast majority of drugs that we currently use. Frankly, the structure that's required to execute on an outcomes-based contract is very substantial and it just doesn't exist. On the other hand, we are about to enter an era of gene therapy, and it will not be unusual for a patient to cost many millions of dollars for a therapy which will undoubtedly be FDA approved at a time where we do not know its durability. And as a consequence, there should be some responsibility on the innovator's part to guarantee that durability. So I am hopeful. The last administration was not enthusiastic about outcomes-based contracting. The current administration will see, but I think several of the innovators in the gene therapy space, Bluebird, for example, I'm sure you've heard, have expressed interest in doing outcomes-based contracts. I really like that idea for very expensive and potentially curative therapy, and I think if we can move that forward, it will insulate us some from rapid to market therapies that may not be as durable as we would perhaps hope they would be. But having, I have to say, having taken care of sickle cell disease in my professional career, that is a scourge on the earth. If we have a therapy that cures sickle cell disease, we should find a way to get it to people. That's my opinion. And then we should find a way to pay for it. So.
Thank you, Michael. So Jack, you're next.
I really enjoyed the talk. Thank you very much. I've got two questions. One is, what do you think the Biden administration's going to do? Rather, what do you think is going to happen? Right? What will be passed? What policies will be different in 4 years' time than they are now? That's the first one. And then the second one is, I always used to worry in my last job, which was in drug and biotech investment, that if the US starts international reference pricing, all that happens is the prices go up everywhere else, right? So I would be interested in your thoughts on that point, that we simply export US high prices and lose access in countries that don't want to pay US prices.
Okay, let's do the second one first. That's an excellent question, because we in my day job talk about this all the time. I will tell you, actually, I'm embarrassed to say that we have clients who've decided that if there's a country in which they don't think they're going to get the price they want, they're just not going to launch. Yeah. They're just not going to launch it, and that I find as reprehensible as anything I've ever heard. It's just ridiculous.
Can I say, we all already see that in microcosm, actually, in Europe. So NICE is a relatively transparent process that signals effectively can be reverse engineered, right? And some companies already choose not to launch expensive drugs in the UK because it would pull down the reference prices in other European countries.
Yeah, so I don't, you guys know sort of the pricing mechanism and the HTA and the kind of the guardrails that determine what price is acceptable, what price is not. I'm not sure that's going to, I think the prices will go up a little bit, but they'll never go up to what they are in the US right now. So, when Trump started this, he was thinking 30%. If we could get a 30% discount, we'll take it. But as I said, when people started crunching the numbers for most favored nation, it was 65% over 7 years, 5 to 7 years. So that's pretty substantial. So if we can meet it halfway, I think we'd be okay. I think the argument, just to close that loop, that that biotech companies will stop innovating because they won't make enough money, it's just baloney. Why would they turn their back on the biggest market in the world? It just doesn't make any sense. So they say it all the time. I just don't believe it. Now, the Biden administration, really hard to predict. Well, we do know a couple things. Number one is that any idea that there was going to be a walking back of the ACA is completely false. I think there'll be increased pressure to expand Medicaid in the states that have not. I think that's good for America and good for everybody. I think that a lot of the other provisions that frequently make the news, like pre-existing conditions, that stuff is all going to be safe. I don't think we're going to see, in terms of payment, Medicare for all, right? This whole idea that we're going to have a national, I don't think that's going to happen. It's just too complicated. Now, whether or not Medicare for people my age, over age 60, let's say, or 55, as a public option, which people can buy into, we might see that. But I think there's so much going on right now, it's hard to imagine that happening in the first 2 years. And remember, the House of Representatives are elected for 2-year terms. So we have an election again in 2 years for the House. The Democrats actually hold a very slim majority right now. And traditionally, for first-term presidents, that first midterm election leads to significant gains in the other party. And if the Republicans become the majority in the House, there is essentially zero chance that those kind of expanded access type models are going to happen. Zero. Now, I do expect actually for there to be some sort of movement on the pricing issue. And the reason for that is because both the Democrats and Republicans are for it, right? So, you know, we've got, there was a bill in the House that was Democrat sponsored, but there was also a bill in the Senate that was Republican sponsored that both get at some sort of price controls. And I think we're going to see that. Exactly what it looks like, I'm not sure of. One thing I am sure of, anything that Trump thought was a good idea, Biden thinks is a bad idea. So if Trump started it, Biden is going to pull it back and throw it in the trash can and start from scratch. That's just the way it is. And that's unfortunate because, like I said, there were some things that they came up with that I thought were interesting.
Even international reference pricing, you think, would be opposed simply because it was a Trump proposal?
They'll call it something else.
But it might be the same
thing. It'll be based on the same kind of thing, right? It'll be based on, but they'll call it something else, right? Right. In fact, as you probably have heard, you know, this whole vaccine thing in the U.S. is Operation Warp Speed. The Biden administration decided they don't like that name. They're going to call it something else. So I'm sure they'll have a big commission. A lot of important people will sit there and think about what to name it. And by then, everybody, I hope, will be immunized. But it's just, you know, when you live in America, you get used to it. My wife gets mad at me for talking back at the television.
Thanks very much.
Sure.
Excellent. Any other questions, comments on Mike's talk? Gervat.
Thank you so much for gives me a very excellent presentation. I'm very naive to this field, but as a Canadian, I have some, I guess, vested interest to protect our supply and prices. So the idea of importing drugs from Canada, would it ever be feasible, or was it just like a political gimmick?
It was a gimmick. It was a gimmick.
So,
All
so that's not a threat at all to us losing.
Yeah. You know, so it's so interesting, right? Because you're going to get me off on one of my rants. You know, Americans say they're very concerned about the cost of drugs. They're not worried about the cost of PD-L1 drugs. They could care less because most Americans, number one, never need those drugs, thank God. And number two, they're so profoundly disintermediated from the cost that it's irrelevant to them. They're worried about the cost of insulin. They're worried about going to the drugstore and having to pay out of pocket. And so drug importation was a really nice solution for that problem, right? I mean, it was about insulin or something like that. It wasn't about specialty pharmacy drugs that are used to treat cancer. Most Americans have absolutely no clue about what these drugs cost. And even if they're getting them, they have no clue about what they really cost because when they get that form from the insurance company, it's Greek to them. They don't bother looking at it. But so the answer is, yeah, it was stupid populist nationalism, nonsense.
All right.
Then you may have been frosted, but thank you.
Michael, that was a really interesting talk, but the very last comment you've just made, that they haven't got a clue about the cost, already shows or demonstrates that the healthcare system in the US is even less transparent than the rest of the world.
Oh, yeah.
And given the fact it is nonetheless the engine driver of what happens to most other countries, because of course, FDA approval is largely mimicked by EMA and such like. Is there any way in which we can improve transparency of that system?
Actually, transparency is part of the issue. The other issue is, of course, health literacy. And I think I think there is a movement in the U.S. towards transparency. As you know, one of the things Trump did before he left was pass that executive order that hospitals had to actually publish their prices. Now, the theory was that people would actually shop, right? They'd look at the price and they would shop. I'm not sure that's going to happen, but there was a really, there have been all these interesting experiments in America that are all pieces of the puzzle, but I'm not smart enough to put them together. A long time ago, there was an experiment in California with California. And California is a huge state, right? And so they have a lot of retired people that used to work in the state system. And the topic of interest was the price of a joint replacement, right? And they looked at the difference in price at the various hospitals. And they were massive. I mean, they were massive. And California Retirement is a big payer. I mean, a big organization. So they said, look, there's no reason it should be this way. This is how much we pay. This is how much we pay. And this is why we pay this much. If you, the beneficiary, the retiree, go to a more expensive hospital, knowing that they charge more than this, it's out of your pocket. And what happened was people migrated to the less expensive hospitals. And not only that, the prices of the more expensive hospitals came down closer to the price of the less expensive hospitals. So what I'm suggesting to you is there may be, I don't think we need to boil the ocean. I think we can take advantage of consumerism. And people in healthcare, it's crazy. They're so cost conscious. I mean, if you look, for example, at the type of healthcare benefit that people chose in the ACA, they chose the cheapest one, even though they knew that if they were unlucky and got sick, they'd have to pay a lot more out of pocket. But they still chose the cheapest one.
So we need to compare the market or meerkats for healthcare then.
Yeah. So you know, I think. So again, having been in this space, I actually think the commercial health insurance companies do successfully manage utilization and cost to an extent. Consumers in America and physicians and hospitals in America don't really like that because it puts up impediments to what they want to do. But I always look to Medicare Advantage. That's where Medicare pays the insurance company a certain amount of money to. And Medicare Advantage has been profoundly successful in this country. And actually, most people who sign up for Medicare Advantage, they really like it. They like it. So there may be a way to take the best of both worlds, you know. But I'm too old to actually figure that out. I'll be retired and on the sidelines, writing a blog and watching it. That's my intention. But anyway, so yeah. But that's a good question, Lisa. I think it does get to the heart of the problem, which is that Americans don't want to wear masks. It drives me insane. I don't.
Sophia, you next and last. So
Thanks.
go ahead, please.
Oh, that's a little bit daunting that I'm the last one. But it's just very quick question because yeah, I didn't realize this. The talk was so profound on kind of the economic system. I thought it was more, but yeah, very complicated. But I think I followed most. It touches me close in when it reminds me of when I went to Australia and I was a consumer in Australia and I saw what was happening there compared to England. I was like, oh, I didn't realize that people really couldn't pay for diabetes tablets. This is mad. But my question is basically almost following with Lisa in that if you guys are trouble, we are trouble back, because once the FDA passes it on, then EMA follows. And so sometimes that happens. So that happens before it's really, with oncology drugs, before it's kind of available for the consumer market. So is apart from kind of reviewing it retrospectively with these outcomes-based payment, which I think I've got the idea, is kind of like a retrospective kind of clawback on the fees. Yes, apart from doing it like that, or doing it as a classic health technology assessment from Europe, which they're not gonna go down that route. Do we have any other options to?
So I actually don't. I'm not sure health technology assessment is completely dead in America. It won't look nice, but there may be a way to adopt health technology assessment and use that to take the brakes, put the brakes on, because I think the FDA, I'm not at all confident that it's going to change. So I apologize in advance for the U.S. regulatory shortcomings, but
Yeah.
Well, on that note of apology for the FDA, I think it's a good time to wrap up. Michael, thank you so much. We learned a lot, all of us, so appreciate your insights. Great discussion. I see Ian disappeared, but we are looking forward to his talk in 2 weeks, and we look forward to seeing you all back in 2 weeks. And well, have a good afternoon on the other end of the ocean, and good evening to everyone else.